Welcome to Calcutta Debating Circle's Clarity.
Welcome, Dr. Sundar Raman. A warm welcome from Kolkata. So, like yourself, we are the cyclone survivors and the COVID warriors. And in Kolkata, we have a small association of argumentative Calcuttans that is called the Calcutta Debating Circle. And it's a great privilege to welcome you on behalf of CDC and Calcutta Debating Circle as well. Now, friends, those of you who've been like all of us, no matter what we do in life, have been completely swept over and engulfed in virology and epidemiology in the last few weeks, would have noticed a few things. And one of these things are that if you look through the world and listen to all the conversation which is happening with the social media, television, print media, then probably more than half of the leading epidemiologists of the world are Indians, are people of Indian origin. But somehow, in the public health domain, in the prominent public health domain of India right now, the battle seems to be led from the front, not by public health. Currently, we have people, chest physicians, pediatricians. There is also a management group from the United States who's given this program a leadership. So I wonder where our epidemiologists had all disappeared. Now, I had the great fortune of having had the chance to interact with somebody like Dr. Sundar Raman a couple of times. And very briefly, we would be dwelling on his CV for a long time, but he is a core health systems expert. Professor Sundar Raman, as a health system expert, has been involved in organizations like the National Health System Resource Center. He's been an advisor to various state governments, including the government of Chhattisgarh. He's been the professor and dean of School of Health Systems at the Tata Institute of Social Sciences. And after retiring from there, he is now the global coordinator of the People's Health Movement. So welcome, Dr. Sundar Raman, once again. And can I start off with the uncomfortable things in the very beginning? That do we lack a proper domain input of people from health systems, from infectious diseases, from disease control systems, leading the Indian program today? What is your take on the issue?
I think so. I think at some point we built up a system, but which was meant exclusively for this situation. That is the National Center for Disease Control, the NCDC. The National Center for Disease Control is particularly meant for epidemic control. It has within it a flu surveillance program. It has a control room from which it can monitor 150,000 reporting units. It has a team, a building. It's housed in a major place in Delhi. It files weekly reports ever since 2010. The last weekly report was filed on February 2nd, when it mentioned very professionally, very well, the first 3 cases of COVID-19 in India. And then it curiously went silent. Imagine, suppose you have a fire station and a fire system, and the moment you have an outbreak of a fire, that disappears. It's something akin to that. The integrated disease surveillance program, somewhere in the background, may have continued to work just completely. Whereas it has been reporting epidemics. You can go back and look at the website now. It reports every epidemic outbreak for the last 10 years, and it went silent. You had a number of new people take over, and clearly many of them were, to put it politely, learning on the job. I could see that some of them got the definition of herd immunity wrong. Some of them got the definitions of basically, and they invented this terrible thing, the stage 1, stage 2, stage 3 of epidemic control. There is no stage 2, stage 3.
Sure.
We actually get this from clinical medicine, especially if you're a clinician and in cancer research. Stage 1 is a very localized disease. Stage 2, it's spread to some extent, but you can surgically correct it. Stage 3, it's gone very far. Stage 4, it's too late. Nothing can be done. That's not the way epidemics work. Epidemics don't have staging in them. You have local transmission, but that's nothing to do with local disease. And at some point, this whole story that was built up of the lockdown as something that will prevent India from entering stage 3 has really no basis.
We'll come to it.
Really...
Yeah, so we'll come to it. Because it really, we have done funny things at funny times. Because currently we have a postgraduate historian who is leading the Reserve Bank of India. And if you look through the Indian bureaucratic hierarchy, I think there will be more such oddities discovered. But really, I think we have felt the vacuum, we have felt the lack of domain competence as far as giving India, a country of 130 crore people, not having domain competence at the top, at the very top when it was necessary, is really a sad phenomenon, and which really necessitated epidemiological quacks like myself who come up and often joined in the conversation. Now you've hit the nail on the head straight away when you mentioned about the idea of a lockdown. Now, can I just tell you that, of course, we are now, today, this Monday is an auspicious day, we are in unlock 1. And you can only unlock something which you have locked at some stage. Fair enough, I think we did. Now, first of all, let me put this hypothesis in front of you. It is said that, do you believe in the hypothesis that lockdown is only necessary in environments, in countries with a weak economy and a weak health system? In rest of the places, lockdown doesn't have a role to play. How do you react to this assumption?
I think that lockdown has to be understood really in thing. Lockdown is a restriction of social movements, of social activities and movements. When you do all of them together, then we use the term lockdown. It's not necessary we do all of them together. It's even less necessary that we do them like a shock treatment, a shock and awe sort of thing, like demonetization or a Balaport strike. It is something that we could have done by giving 1 week notice, asking people to take preparations, quietly get it down and done that. Now, lockdown has 2 rationales, and we must be very clear about which one we are using. One rationale for the lockdown, actually 3, but one lockdown is that it gives you time for the health system to prepare, because we are so unprepared. We didn't have testing kits, we didn't have even know, we can't inform all the people. So you could have given 1 week notice and 3 weeks for preparation time. That's one logic. The other logic is of containment. Containment really hopes that you are able to bring your disease transmission down below what is called an R0 of 1, make it endemic, and therefore quash the disease. That was really not possible. But we went for that option, and we were so ill-prepared and planned for it and so unreal to our Indian context that it was an exercise that has failed, and we can see that along. As health system preparedness, it could have worked. Did it work is another question. But as containment, it really wasn't there within the range of a possible working situation on that. So I think we will need to actually check the third possibility of flattening the curve is a very relative term. That's what we actually landed doing. But the problem with that understanding is it only delays, it defers the spread of the epidemic. But it's like a raft on which you are using to get to the shore. But if you don't reach the shore fast enough, you will die trying, because the stress of trying to reach the shore is too high. So the mitigation strategy is really, given our huge problems of the migrant labor, of lack of social distancing impossibility of social distancing, is something that we should have done with far more limited restrictions than altogether a sudden lockdown. So one has to really understand that, and at some point the government got it quite wrong. They talked of health systems preparedness, but they went in for a containment. To some extent, Kerala managed that. To some extent, to my own surprise, Kerala did manage it quite well, and I have some reasons why they did. But nobody else got anywhere near there. All they could do was a sort of mitigation and delaying the epidemic. So now we are going to have the epidemic grow, and we are going to see it peak. We are not even halfway up the peak, and we are going to see it peak in the coming 2 months. So we've just spent 2 times of enormous suffering for the people, and we've just not actually done too much to the epidemic itself.
So in a scale of 1 to 10, how much would you score, give it a score on the 69th day of the lockdown as of last Sunday? How much did we actually achieve based on your 3 parameters that you said: time, preparedness, and mitigation?
So on mitigation, I would give it a good score. I would say, definitely, while we don't need to go with the Niti Aayog projections, definitely there would have been more deaths and cases by now, but for the lockdown. You have paid a huge cost, but that in terms of mitigation, there has been something. In terms of containment, it's a 0. Okay. And in terms of health systems preparedness, it varies. But unfortunately, let me say, I'd give it a 3 or 4 out of 10, and I'll tell you exactly why. But basically, if it had not been, it would have been even worse off for that. So there was somewhere, some states have done reasonable preparation. Many states have not really anticipated it. They thought containment was going to happen, but now they see the epidemic breaking out, and they have not yet really readied for that. So that's the whole issue. They sort of fooled themselves with their own positive narratives, and now they are faced with it. So it's a mixed bag. But
right. Yeah. Should we forget it later on in the discussion? Since you have mentioned it, briefly, could you highlight to us the points? Where did you think Kerala succeeded? What were their strong points?
So I think where Kerala did, and I don't think as tactics, as formal strategy, they did anything very new. But they had, let me say, 2 or 3 background factors that made a huge difference. First and foremost, they had brilliant contact tracing, huge public cooperation. For every single case, they identified over 100 contacts and quarantined them. That's because the police, it was not a policing job. It was actually done by panchayats with a lot of people's participation, and they had a pre-existing system of outreach under the panchayats. So there was a lot of trust between the government provider, the panchayat, and the people. So that came very handy. It also meant that home quarantines could be managed very well. I think this was their first thing. A second factor that very few people have recognized is they had a Nipah virus outbreak, not once, but twice in the preceding years. One of the things they learned at the Nipah virus was that the single biggest source of infection was the hospital itself, nosocomial spread, and to the doctors themselves. So they learned how you actually do a quality management in the outpatient triaging system so that you do not allow hospital-acquired infections. If you see, every other state has reported a large number of healthcare providers who are affected by COVID-19. Kerala has a few, but very little. And they have done remarkably well, and therefore they could bring patients confidently for testing because they knew they were not afraid of doing so. So I think that was a very big factor that they did not stigmatize the disease. All this business of Tablighi, Jamaat, that really created a community orientation and a scare. For that community, it's one problem. But the other communities don't want to confess having the disease because they too get stigmatized. Not only that, there were many forms of stigma. Kerala was relatively free of the problem of stigma top to bottom. And that was, I think, somewhat a very, very helpful thing. So I think there were these many factors so they never really got into the hospital stage. So we don't know. They were prepared for the hospitals, but we don't know whether it would have worked. It probably would have, but they never got to it. They contained it by brilliant contact tracing, isolation,
Absolutely.
and things. Yeah.
Absolutely, sir. Now, you've already touched on it, but we just want to clarify our ideas and concepts a little bit more. Is it a fair thing to say that, very often we have noticed that in many systems, in many states, we were dealing with this containment business like a law and order issue.
I think
so did it really serve any purpose? The red, green zone, blocking streets.
So you look at the world experience also. The entire world experience was like New Zealand. You had lockdown, or some places didn't have lockdown, but you had success where your focus was on contact tracing, testing, isolation. Without that, it didn't work. It didn't even work for smallpox vaccination. Let me remind you, for old timers, with vaccination, we didn't do well, but the moment we had isolation, contact tracing, smallpox eradication happened. So at some point, it's an old lesson that it's not now contact tracing and isolation is a very social work, community engagement, public work. Whereas the national disaster management cell, quite a thing, is very Ministry of Home Affairs, it's security oriented, policing oriented. So all its restrictions come from the police mindset, and that's a disaster. Look at one example. After 7 p.m., you have a curfew. Why? What public health sense is there? What's going to happen after 7 p.m.? Does the virus start spreading dramatically? Do people get more infected? Do vampire bats appear? Nothing. There's absolutely no rationale. What about this 5 kilometer circle with a 3 kilometer buffer? What's this about buffer and circle? If my neighbor next door has got coronavirus, am I at greater risk for coronavirus? No, I'm not at greater risk for coronavirus. I'm at greater risk if I'm entering his house, whether I'm 1 kilometer away or 20 kilometers away. Now, the difference is that if you were to go contact tracing wise, you'll need social workers, volunteers, community. But if you have geography wise, then you have a police basti, you have a bandobast, you have a band on the road, and the Ministry of Home Affairs has control. So somewhere this instinct of policing, and that too at some level, I mean, you can understand police will be police. So they will take money when you have to open a shop, or there will be transgressions at some point. I don't want to make too much of the transgressions. I'm saying that fundamentally the police should be a backup. It's something somewhere quietly in the rear. The front line should be community engagement. And I think that's one of the big issues. The problem is also of very good primary care networks. So one of the reasons why urban areas, it's not only density. There are studies that have shown from Wuhan that population density alone is not the factor. The thing is, in Kerala, you have a large primary care network with ASHA workers, with other people, and all of them are trained and deployed. Within urban Bombay, the KEM hospital does the primary care equivalent to 100 PHCs. The PHC network, the outreach service, other than pulse polio, there is just nothing there. Pulse polio is the only form of outreach that the urban slum knows. And within such a situation, your ability to communicate message, to support a home quarantine, to educate people, to identify cases early, all of these are crippled. So it is part of the legacy of what we have failed to do in urban health planning. That is what we are really paying a price for now. Must remember.
Sir, yes. I mean that those are absolutely very very true, sir. Now you see this kind of aberrant epidemiological behavior that we've seen from Maharashtra, Gujarat, Delhi, and rather unexpectedly Tamil Nadu. So how would you is there a sweeping explanation for this high incidence, the inability of these states to bring their numbers into some kind of sober limits? What explains this persistent rogue behavior of these four states? How do you see that?
I, I, I I think I would not characterize it that way as these states. Let me tell you, if you have read the history of the 1918 flu pandemic, it happened so identically to this one that you must look at something much more. It happened to the returning ships from First World War soldiers. They called it the Bombay fever. And the second center was Chennai. And then it spread towards with the railways to UP, Bihar, and Bengal. And you have a very, very similar pattern going on now. Now, these are the big ports of entry of the airport. And you know that this came in from the international thing, and then it spreads.
Yeah.
But then, therefore, these are the Delhi, Bombay, this comes in. Then, of course, Trivandrum, Goa is also international centers. They didn't have it. So this is not as if you must have it. It's just that this is one. But the point about it is once it starts spreading within, the extent that you are able to deploy testing and you are able to deploy identification and isolation as a strategy has great limitations in places where you have a very adversarial relationship between community and the state. So you must remember that Delhi was recovering from a riot zone situation, a complete breakdown of things. Ahmedabad is ghettoized in many ways. There's also a very weak and very difficult, very unequal populations, high degrees of inequity. And Dharavi slum is, I think the world knows about it, but all of Bombay has this whole differences. We did not also imagine, we did not even think of the migrant. The existence of the migrant was an afterthought. In the March 23rd
so we'll come to the migrants. Just give us your reading of the Tamil Nadu situation.
So the Tamil Nadu is interesting. The Tamil Nadu actually, for the first 1 month, they were neck to neck with Kerala. And we were very hopeful that Tamil Nadu is going to crack it. It was on containment. I can't quite place my finger on it, but two things happened. In between, they got carried away by one vertical chain of transmission, and they went on saying that 90% is from this, otherwise it's not there. They failed to test wider across different centers and keep a surveillance program. So their clusters grew until they became large clusters, and then each time they were blamed. So from the Coimbatore market, they had a second cluster. Now Tamil Nadu is in a bit of a runaway situation, and I am very worried for Tamil Nadu. I am even at this point of time worried that it will match or surpass Bombay also, because the last 3 days has been, the news is very bad. At some point, it's very worrying. It's very worrying. And the reason why it is so is because, again, we have not really managed within the Chennai ambience a good program of things. People are hiding from the persons coming around. They're trying to ban paracetamol because if people take paracetamol when somebody comes, so that they are not caught with the fever. That shouldn't be. People should be, if you are ill and you are ill with a dangerous illness, you should actually be reaching out to the health facility. If you hide from the health facility, that itself is a harbinger of bad news. No? So I think that now people are moving out because more deaths are beginning to happen. But I don't think they are geared up to managing severe cases. And I am very worried that some degree of complacence that set in at the period of the second lockdown and denial, a failure to test. It's not the absolute number of tests that's important. It is the deployment of the tests, whom you test. Somewhere there, they seem to have missed the bus. So they are and they need not have been, because Tamil Nadu does have a relatively good healthcare system.
Yeah, that was disappointing. Seeing these numbers from Tamil Nadu is disappointing. Now, before we come to the vexed issue of the migrants, I just wanted to have your input in. What do you think happened? They did all this antibiotics. And along with it, sir, you see, almost there was a regularity. Every few days we were reading in the press and the media, some new test has come from India, some new test has come from Pune, from Chennai, from here, Delhi, Calcutta. What happened to all these Indian innovations? And where did the antibody test finally land up into? Is it lost forever? What's happened, sir?
Yeah, that's a really sad story. I have something like Karnataka. India is the pharmacy of the third world. We supply drugs to everybody in the world. But at our moment of great need, neither our testing kits, nor our medicines, nor our capacity for vaccines, nor we are the great vaccine suppliers. Nothing could be of use for us. So I really think it's difficult. All of it, and to a surprising and shocking degree, when we ordered for personal protective equipment or testing kits, we sanctioned some 30 companies, of which 27 were from China. The 2 or 3 from South Korea and Israel, and Indians, there were only 1 or 2 who said at that time they are going to start and ramp up production by 2 weeks, and we still haven't heard where they have gone. So this sudden, this particular loss of indigenous manufacturing capacity on these essential health commodities is something that we need to seriously review as to how that particular thing happened and how it continues. So hopefully there are efforts still, but it's a bit difficult. The difference is this: antibody tests are a bit inherently difficult to standardize and validate in a particular way. Okay, so it's easy to somewhat get manufacturing, but it takes a bit of time, it takes feedback, it takes a system, and those systems were disrupted. Antigen tests, on the other hand, they are costly, but they can be done. But somehow we did not, it's a bit, we should have done much better. Part of the reason is we gave, if you look at when government finally gave the orders for ramping up production, much of them were after the lockdown was announced. Whereas the countries that did well were people who had in the first week of February already started the manufacture and the test kits. We lost 1.5 months, and when it came to PPE, 2.5 months before we placed the orders. So very, very delayed, very underplayed. Even our estimations of the quantity required. At one time, ICMR was very proud that it could do 10,000 tests per day. They didn't even understand that the tests that we require are on lakhs per day. So at some point, it is very, very much of a learning curve. I think they have learned, but they learned on the job. No past prior experience came to their aid. And I think this is, I hope, we don't have another, but if we have another,
yeah, that's right. We don't want another one, but neither do you want to learn in the job like this. I mean, a very respected person. I adore him, Dr. Srinath Reddy. Disappointingly, he wrote a big editorial on contextual testing when we were testing about 25,000 per day. He almost said that was enough, and that was the limit. We don't need to go above that. Anyway, we have crawled up to some.
On this testing, there is one thing I have a problem with all these clinicians who said that. All of them were making a case for testing for treatment of severe cases. They did not understand that testing is essential for planning disease surveillance and control measures. They did not understand that if you do not test and isolate them early, disease will spread. And finally, they did not understand that if you have home isolation, they will slip into hypoxemia and severity without knowing. You do need to hospitalize mild and moderate cases unless you have a very upper middle class house with very great links with people. So I think we have made multiple things, and I think many of the people who came on television there underemphasized the importance of testing and isolation of and going after mild and moderate cases. Even today, sir, and this is the tragedy, even today, if you are symptomatic with COVID-19 like symptoms and you go and say, please get me tested, you don't have a right to get tested. They'll say you are not in a containment area or a hotspot, then only we'll test you. So how do you know there is no new cluster unless you test? So it's a circuitous logic. You say there is no transmission and you don't test them. And then because you don't test them, you don't have community transmission. I think this was, and either they didn't understand. Yeah.
Yeah, you're absolutely so correct. I mean, personally, I'm terribly worried that keeping all these mild cases at home, and it's sometimes, depending upon their situation, is sometimes a very risky thing to do. So we try to work on something that whereby these mild people can be at least monitored at home and not leave them to fate and destiny. Now let us come to, we've covered, taken a significant amount of your time, but no discussion today on this theme can be complete without discussing this great rumor that happened with this handling of what we call the migrant laborers. Now I still haven't understood what little knowledge I have of the Indian constitution. How can a Indian be migrant in another part of India? I've never understood that. But given the fact they are, and given the fact that, even if a high school student for a project looked back through Google, there are NOSS and everything from 2011, 2012, which tells us that we have a 2.5 crore, 3 crore volatile, unstable, fragile workforce base. So knowing all that and going in for an abrupt lockdown on May 24th, in your opinion, how best could we have managed the situation? One option was they stick where they are. We were under a pandemic act, so the central government could have ruled that stop your disagreements. We have to look after them where they are, or we could have moved them out in the first month or first 15 days itself and not waited till this advanced stage of high infectivity. How would you have managed it, sir?
There is absolutely no doubt in my mind. It was the humane thing to do. It was the public health thing to do. It was the scientific thing to do. We should have allowed them to reach their area of comfort for managing a lockdown and settle. Families should have reunited. People should have gone to their homes. At that time, if we had done it, how many cases were there on March 23rd? Some 400, 500 cases.
400.
All of India. Even if you say there were double that amount and all of them disappeared to villages, you would have had a few cases and those few sources could have been contained. Instead, we did perhaps the worst possible thing. We caught them on the streets and interned them, brought them into enclosed spaces and put them together in confined buildings. When you do that, and this is well known in the models outside, that when you ban community mixing and public transport, then household contact increases. Here there is no household. Most of them are individuals. And therefore the labor camp is their household. So actually you incubated and sort of cultured the disease in these centers of these labor camps. And then when they get under pressure, you are releasing it. So you've done worse than what you could have done if you had done nothing. At some point, if you had done nothing, those 400 would have gone off. But if you have done this, you have actually... So I think this was a serious thing. And I think if we had led with the ethics, we had led with the humanity, that these people must first not be seen as a vector of a disease, but as a rights bearer. What do I mean? If a migrant is sick, I don't say, oh, he's sick, he will bring sickness. I say, he is sick, he must be treated. That is my duty, wherever he is. So if he's coming with sickness, my question is, why is he coming with sickness? He should have been treated there. The moment you decided to treat live human beings as vectors of disease who needed to be contained, you had already gone down that slippery slope. And we've landed up in a situation where we could have fully avoided. And at some point, I think this is a very great, but somewhere this whole decision-making privileged elite just don't have if you looked at the first day messages on 23rd, 24th, They're all about messages to people with balconies, 3 bedrooms, who had to give their maid a chutti so that the maid can be from home. That means you were talking to people who had housemates. You were not talking to the housemates. You were talking to people who were in the industrial class. So you were clearly not thought of the poor at all, of what would happen in the lockdown. And later, when you saw those scenes coming in from the railway stations, you suddenly started making plans for the migrant. This is what we do for this is what we do for all plans. But unfortunately, here we paid a very brutal price for it. They paid a price much more than anybody else. I think after the partition of India, this is the greatest migration and our greatest the greatest act of shame. I feel so terrible and ashamed that at some point we hadn't cried this out much earlier and forced them to, even if necessary, go at all times. But this is something that's really terrible.
Actually, there were some very senior, they will remain nameless for the time being. Congress leaders during the partition, they spoke from Calcutta, from Bengal, saying that they never imagined that so many people would be affected in this redrawing of national boundaries. God bless them, they're in better places now. But this has been an event of national shame. And you will see that in international discourse right now, many countries being discussed regarding this COVID management and everything. People don't even bring up the discussion of India, because if they did, then this almost human right violation will come to force. Sad, very sad as it is. And we find ourselves to be at the receiving end of this service. Sir, asking you a difficult question. You are such a forthright man. You do not shy away from difficult answers. Every country, to some extent, has, by intention or by accident, fudged their figures. There is figure fudging happening. We know UK coming up and saying, probably we are underreporting our nursing home deaths by 20%. US, probably a little less so. Italians are still adding to their numbers. Currently, in India, we are reporting slightly more than 3 deaths per million population. And we know, like the reporter who did a kind of reconciliation of deaths in the Delhi mortuary, the Delhi burning carts and everything, they found a huge discrepancy of more than 50%. In Calcutta, we spent the first month of COVID campaign trying to manage data and doctors, and then we looked at the disease in that order. Anyway, I think we did do some good moves at that stage. But do you think that there is a significant amount of underreporting, whether it is death, etc., happening or can happen in the Indian situation at this point of time?
Definitely a major level of underreporting. I say this with great pain. I do understand that there are difficulties in sort of asserting this without a sort of evidence that one can share. But I've been a long-time person in the system. I have friends who work in different departments within the health sector. I've worked my entire life within them, so I know people. And I can tell you that definitely there is a huge amount of underreporting of deaths. This is undeniable. You correctly pointed out that many countries underreport deaths. That is true. But they do it in a way in which they say that, listen, we are missing out on care homes, so this is an underreport. What differentiates India is we underreport deaths and we then claim that we have made a rare achievement compared to all other countries. If we can even stop saying that, I would settle for these numbers. I'm not really worried about, you can see if you plot the GDP of the country against the number of deaths per million, the poorer the country, the poorer the lesser the deaths. Is obviously the fact that our ability to capture these events and to be able to present them have serious limitations within our situation, which we can understand and live with. I don't expect them to be able to go away in a day. But then we link it up with bragging about being the the best containment in anywhere in the world, which is something that fails. At that point, one needs to then get up and say, no, you're calculating your case fatality wrong. You're not testing even mild and moderate. Everybody else in the world tests mild and moderate. So that itself means 80% more will come just by sheer virtue of testing that. Your death reporting systems have not got the basic cause of death reporting in most of the situations. So you have to then point out that please don't think that this is just make a mention of it. This is the problem. The problem in India becomes that we need to maintain a narrative that is being constructed above. We are not even willing to go with what is happening. We create a narrative and then try to fit the data and the findings to suit that narrative. We could have just said that, look, we are having so many cases. Even if we had not got, we've had 5 times more cases. People wouldn't have said anything. There's an epidemic on. We know that. But in this narrative of this bold man who has completely solved India's problem, we seem to have lost it. It's unfortunately
Yes, sir. So well put. Today I believe we have climbed up to the 7th spot in the Corona ATP rankings, and that is, I think, where we belong in the world GDP scale as well. Definitely not in the per capita GDP, but in the
we'll reach our position on the GDP, absolute GDP.
Yes, I think
we will reach
and there is slightly, an air of cynicism. There is a slightly different, they say that we only have 5% elderly population in India, which we will have with a health system which is so inadequate. Because more inadequate the health system, lesser is the elderly population, because nobody lives long enough to be old.
Absolutely.
So anyway, I hope no minister comes back and tells us that we have got the benefit for having a poorly constructed health system. Fair enough. So we've taken, I think, we would like to have your thoughts on that. With a lot of rumble, with a lot of confusion of policy, with a lot of deficits which are apparent in the domain competence of leading this program, where on to from here? What is the way ahead as you see it?
So, I think the first thing that needs to be said is we must move away from lockdowns. We should use judicially and evidence-driven restrictions of certain social activities and movements, especially any gathering within an enclosed, even worse, air-conditioned space. I am highlighting this because this has not yet been said enough in literature, that the point about these enclosed spaces and the way they circulate air within seems to be acting as super spreaders and certain types of gatherings. So if you are in a bar and restaurant, you please go, and something which is open air will be far safer than something that is in an enclosed space and circulating that within the air. So there are certain sensible rules to follow. That's my general point. There are certain sensible rules to follow that will lower it. But having said that, absolute across the board restrictions are not helpful. They have not been helping. They won't contain. What you do need, though, is very, very easy access for anybody with a symptom to be tested within 24 hours and get a report within that same 24 hours. It is not too much to ask. We should be able to get on request a testing in, say, 20 places. The sample is collected and reported. It's not too much. Second, we should have isolation for everybody who tests positive. Asymptomatic, we can think about it at home, but definitely symptomatic, we should not think about it at home, and even asymptomatic should be under close observation, for which we will need to greatly increase the number of isolation beds and convert a number of hotels, etc., into isolation facilities, which is different from quarantine. I think very few understand this difference. Quarantine has its own requirements and isolation. I'm talking about isolation. Quarantine is a different thing. The third, I think, is we really must do much better on the treatment of severe cases. I think the fact that we have very few people on ventilators is because we are losing them early. I think we are not doing enough on the severe case management. We are in a state of denial. We are fighting them too late. We have not got them in case. So I think hospital management itself, this whole practice on severe cases is something that we should do much better. And
Sir, how important is social distancing?
It is very important, but it must be sensibly done. If you say don't touch your face, I mean, you can say that. There's no harm in saying that. You keep saying that. But you do touch your face. It's as unfeasible for you as in Dharavi, physical distancing is unfeasible. So there are certain things that people must understand the principles and build around that. Social distancing will do what? It will do mitigation. It will reduce the total number who fall sick at a given point of time. The total area under the curve may not decrease, but it will until the vaccine comes. But it will at least help slow down the spread. And that is very important. But it is hand washing, masks in gatherings, and especially if you are in meeting 3 or 4 people, even masks are useful. Or if you are feeling unwell, masks are thing. Plus a certain degree of sensible avoiding gatherings, and especially gatherings in enclosed spaces, especially gatherings in enclosed air-conditioned spaces. So these sort of rules, if we follow, these are the social distancing we need to follow.
I think absolutely. And probably, the last story question, are you betting on the vaccine?
Yes. And I'm betting. There are 3 vaccines. There are a few. I follow this in great detail. I'm in touch with some of the international groups like Medicine Sans Frontiers, which are following.
Yeah.
So we are hopeful of the vaccine, but we have got mixed news. So on medicines, by the way, the internal news amongst the sort of groups that I follow is that none of the medicines are working. Yes. All this remdesivir, all this flavopentanil, all so much expectations being aroused, they are not really working. But maybe they will. But vaccines, we are hopeful. The Oxford vaccine, not too sure. Moderna is under testing. These are 2 vaccines we know. But quietly we think the Chinese are at it. And we are going to, and Xi has gracefully taken over on the WHO and announced that he will make it a global public good. In the WHO, there's a big argument about whether vaccination is the global public good or vaccine. And these people are going to bring a vaccine, and they're going to make it universally available, and then we'll have a new geopolitical regime on that. The vaccine has become very critical, but I am hopeful of the vaccine. I think that by next March, we should be able to have a vaccine that is accessible. But India is India. To vaccinate everybody will take 2 years from there.
I know. As it is said, that China is now mass producing 2 things. They are mass producing T-shirts for India, which says do not buy anything Chinese. And the second thing is that when the Chinese do hit the market with a vaccine, probably we can't wear those T-shirts anymore. Sir, we are so grateful to you for your clarity, for your boldness. I've learned a lot, and I think everybody listening into you have as well. I think let us get to a happier side of the curve in a few weeks' time, and I think I at least will not be able to resist the temptation to have a second part of discussion with you again. It is always such a wonderful learning experience. A big thank you from Calcutta.
My pleasure. Thank you very much.
Thank you, sir. Thank you.